Welcome to this talk. This year, 2025, we had a lot of new papers challenging the status quo related to the treatment of hypertension. Usually when we talk about high blood pressure, the standard diet is the DASH diet, a diet that is low in sodium, high in potassium, high in magnesium. However, a new theory has increased the interest in research this year. This theory proposed that actually the main cause of hypertension is not sodium, it's actually sugar. This is the rationale of the theory. Theory claims that high insulin is the cause of high blood pressure. High insulin holds sodium, and at the same time, high insulin activates adrenaline, which is a vasoconstrictor, and that leads to high blood pressure. Based on this theory, several RCTs have been conducted, comparing the DASH diet with a low-carbohydrate diet. Many of them have shown that a low-carbohydrate diet is actually more effective in reducing blood pressure. Now, I want you to be aware that these are just theories. The DASH diet, or the Mediterranean diet, or the low-carbohydrate diet, they are just theories. None of them are 100% effective. None of them are 100% true. In the medical field, we only have theories. There are no laws. In physics, we have laws. For instance, the law of thermodynamics. It happens all the time. It's a law. We don't have that in the medical field. So the reason why we learn theories is not to prove that a theory is better than the other. It's to know all of them so we can decide which one is a better fit for a particular patient. Maybe for patient one, theory, the DASH diet is better. Maybe for patient two, a low-carbohydrate diet is better. That's the whole point of science. So let's review the paper. First, let's review a meta-analysis. Meta-analysis is basically when you pull all the RCTs, you combine the data, and you reanalyze it. The idea of a meta-analysis is that you're going to have more external validity because you are pulling studies from different countries, studies that use different populations, different ethnicities. Therefore, you have more power, not only because the sample size is bigger, but you can actually generalize because now you are picking different populations and you are able to validate the results in a bigger population from different countries. Most likely the result is true. So these meta-analyses have been published this year. Let's share the screen. Effectiveness and safety of intermittent fasting on blood pressure in adults with overweight or obesity. A systematic review. Let's just check the abstract. So basically what they are doing is they pick 15 studies, right? That's a big sample size, 929 patients. They pull the data and they review the effects of intermittent fasting on blood pressure. The overall result is that intermittent fasting, by reducing insulin, actually decrease blood pressure. Now, these are the numbers in the meta-analysis. Systolic blood pressure was decreased by 4.43 millimeters of mercury, and diastolic blood pressure by 2 millimeters of mercury. Now, many are going to question these numbers, right? Because these numbers may be statistically significant. However, maybe they are not clinically relevant. A decrease of 2 points in diastolic blood pressure may be not clinically relevant to your patient. That's your decision. You decide if these numbers are clinically relevant or not. The point of doing a meta-analysis is to show a statistical significance. But again, be aware that you must do the clinical analysis to decide if something is useful to your patient or not. These numbers look small, right? It's a small decrease, even though it's significant. Now, be aware that one of the big disadvantages of this meta-analysis is that they consider studies that include people with normal blood pressure. Now, of course, when you recruit people with normal blood pressure in some studies, the change is minimal. And that affects the overall result. If you exclude those studies that recruit people with normal blood pressure, the decrease in diastolic and systolic is actually a lot bigger. Those are limitations, right? When you pull data together. The study also tried to assess the reason of the decrease in blood pressure. And in order to do that, they measure BMI, waist circumference, to see changes in weight, body fat percentage. They measure HOMA, the model for insulin resistance, right? And all the lipid panel. And they prove that basically the reason why blood pressure decreased is because the insulin release was lower. Lower insulin, weight loss was achieved in most of the studies. Insulin resistance has decreased according to the HOMA model. No change in cholesterol, LDL, HDL. However, a significant decrease in triglycerides, which usually reflects better glucose management, right? Glucose directly affects triglyceride levels. To confirm their theory that is actually high insulin the reason for the high blood pressure in these particular patients. Now, when we talk about intermittent fasting, they use intermittent fasting, right? But they have 3 different categories of intermittent fasting. One is just the restricted, time-restricted eating, which basically they don't eat for 12, 14, 16 hours, right? Alternate day fasting, they fast for 1 day, or they reduce the calories to 25% for 1 day, and the other day they can eat whatever they want. And the last category is the period fasting, when they actually fast for more than 1 day a week. Usually was 5-2, 2 days of fasting every single week. And that kind of fasting, the period fasting, with at least 2 days of fasting every single week, no food at all during those 2 days, was the most effective in reducing blood pressure, weight loss, triglycerides, insulin resistance, and the overall metabolic panel. So, limitations of this study. As we mentioned before, one of the big limitations is that they didn't control for calorie intake in most of these studies, in most of the original RCTs. They just focus on the fasting, 2 days of fasting per week, 1 day per week, or just restricted time eating, right? Hours, but not really a calorie control, how many calories they were eating. We assume that the protocol, when they fast for 2 days a week, is not only effective because of the fasting, but it's also effective because of the calorie restriction, right? So that is a limitation. There was no control for that. Another limitation, as we mentioned before, is that some studies include people with normal blood pressure, which again decrease the effect. So the effect could also be more dramatic if only people with hypertension were included in the studies. What are the advantages of this kind of meta-analysis? Well, as we mentioned before, big external validity, which means we can generalize to several populations. And again, they reinforce the theory that intermittent fasting may improve endothelial function through ketone-induced inhibition of HDAC1 and activation of SIRT1, enhancing nitric oxide mediated vasodilation. These effects appear more pronounced in adults over 45 years, potentially due to their higher baseline vascular dysfunction, consistent with prior meta-analysis. So again, support for the theory that a diet that leads to low insulin, which means less carbohydrates, or in this case, fasting for several hours, is highly effective in reducing blood pressure. In another video, I will cover RCTs when they actually compare the DASH diet versus a low carbohydrate diet, and the low carbohydrate diet seems to be more effective than the DASH diet. But that's a topic for a different video. Let me know your comments, your ideas, your suggestions. I will try to do these videos analyzing papers, mainly RCTs, when we can go over different mistakes that they do and the limitations that they have. Thanks for watching.